The objectives of this presentation are to describe a multidimensional approach to Parkinson's disease, to discuss the diagnostic criteria, and to compare conditions misdiagnosed as Parkinson's disease. Drug and non-drug therapies will be listed, and you will be provided recommendations for practice. Parkinson's disease occurs throughout the world in all ethnic groups, with a slight male predominance and highest prevalence among whites. The lowest occurrence is among Asians and African blacks. Age is the most consistent factor related to Parkinson's disease, with an exponential increase between ages 65 and 90 and only 5 to 10% of patients having symptoms before age 40. Parkinson's disease course can be characterized in 3 stages. A premotor phase with aspecific non-motor symptoms, a clinically evident stage with classic motor symptoms, and a disease stage with aspecific non-motor complications. Each stage may last approximately 10 years, but variability is common. In geriatric terms, these stages can be labeled as pre-frail, frail, and disabled. There are corresponding brain changes with each of the stages. The locus coeruleus and dorsal 9 and 10 nucleus associated with premotor symptoms, mesocortex and substantia nigra associated with the classic bradykinesia, rigidity, tremor, and postural instability symptoms, and the neocortex associated with memory impairment late in the course of the disease. There is no biologic marker or instrument, like a Dr. Seuss gerioscopy, to confirm the diagnosis, which leads to underdiagnosis and incorrect diagnoses. The diagnosis is based on bradykinesia and at least one of the symptoms of rigidity, tremor, or postural instability. Parkinson's disease can best be differentiated from other Parkinsonisms by asymmetry, resting tremor, and good response to levodopa. Several conditions are misdiagnosed as Parkinson's disease. Essential tremor is common and associated with the family history, is symmetric, flexion, and extension in character, improves with rest, and may affect the head and voice. Vascular Parkinsonism results from strokes and may present with prominent lower extremity symptoms. Drug-induced disease is symmetric and diagnosed by history and improvement with discontinuation of the offending agent. Lewy body dementia is characterized by visual hallucinations early in the course of the illness. Progressive supranuclear palsy impacts downward gaze, and severe symptomatic dysautonomia is common in multisystem atrophy. The tremor of Parkinson's disease is asymmetric, prominent in the hands, and evident in the resting state. Its frequency is 4 to 6 Hz, is supination and pronation in character, but absent in about 25% of cases. Rigidity is noted by increased muscle tone throughout the range of motion and must be differentiated from spasticity. By itself, rigidity is not disabling. Bradykinesia is very disabling and is characterized by delay in starting movements, slowness and poverty of movements, and arrest of ongoing movements. Postural instability leads to inability to maintain balance and results in falls. The individual cannot adjust to abrupt changes in position. The standard way of characterizing the stage of the disease is the use of the Hain and Yahr scale. Stage 0 is treated disease with no signs or symptoms. In Stage 1, one side of the body is affected. In Stage 2 disease, there is bilateral involvement without imbalance. In Stage 3, There is postural instability, but the patient remains independent. In stage 4, the patient is able to walk but has significant reduction in ADLs. And in stage 5, the patient is non-ambulatory. Decision to start medical therapy should be based on several factors, such as, is the disease affecting the dominant hand? Is there significant bradykinesia or gait disturbance? And what is the patient's personal philosophy regarding drug use? The decision to initiate drug therapy should ultimately be based on the degree to which the disease affects function. There are no protective therapies. Therapy can start with 1/2 tablet TID of Sinemet and work up to a full tablet TID as tolerated. If there's no response to a levodopa dose of 1,000 to 1,500 milligrams per day, rethink the diagnosis. Levodopa is of benefit over the course of the illness and increases life expectancy. The anticholinergic, Artane, may be beneficial early in the disease course but has limited use in older populations because of side effects. Rasagiline, an MAOB inhibitor, or entacapone, a COMT inhibitor, may be added to levodopa to treat motor complications. About a third of patients have a good response to non-ergot dopamine agonists, which are infrequently associated with fluctuations or dyskinesias. Treatment eventually requires supplementary levodopa, but dopamine agonist treatment may be adequate alone for 2 to 5 years. Rotigotine 24-hour patches may help improve compliance compared to the oral preparation, which is prescribed 3 times daily. Deep brain stimulation is used for intolerable dyskinesias or motor fluctuation while on levodopa. Appropriate candidates have relatively intact cognition and are less than 70 years old. Benefits include reduction in levodopa dose, improvement in off-medication function, and reduced dyskinesias when taking medication. Risks include depression, decreased verbal fluency, increased falls, and impulsivity. The usual elder services that are available in the community are valuable for the patient and family. Physical therapy may reduce disability and improve gait. In-home occupational therapy may help patients maintain family, social, and work roles, as well as improve safety. Intensive speech therapy for 2 weeks can improve voice problems, and gain may last up to 3 months. Assisted devices, such as a button hook, can facilitate dressing, and weighted utensils may reduce tremor and improve self-feeding. The front-wheeled walker is an excellent tool to help in gait stability and reduce the risk of falls. The initial treatment of Parkinson's disease, backed by good quality patient-oriented evidence, includes the use of carbidopa-levodopa, non-ergot dopamine agonists, or monoamine oxidase B inhibitors. Dopamine agonists, COMT inhibitors, and monoamine oxidase B inhibitors can be added to levodopa to treat motor complications. There is inconsistent evidence for the use of amantadine for dyskinesias in advanced disease, deep brain stimulation for functional impairment despite optimal medical treatment, and physical therapy to improve gait and speech therapy to improve speech volume. Consensus and usual practice supports that physicians with limited experience should refer patients to confirm a diagnosis, and that occupational therapy may help patients maintain family, social, and work roles and improve safety. Remember that Parkinson's disease is associated with a high incidence of dementia and depression during the course of this illness. This chronic disease impacts many aspects of daily life, both for the patient and the family. Isolation and loneliness may result, but is not an inevitable outcome of this geriatric condition. In conclusion, we may identify three major phases of Parkinson's disease which correspond to the geriatric terms of frailty in situ, frailty, and activities of daily living disability. The premotor phase may involve nonspecific symptoms and depression. Specific motor symptoms of the second phase define the diagnosis of Parkinson's disease. And the final phase of complications includes memory impairment and disabilities from other geriatric syndromes.